Jeffrey to unmute himself and open the camera to be recognized and say a few words to Professor Jean, okay, and the rest of the group. Okay, Jeffrey, are you here? If you are, you please unmute yourself. Okay, I see Jeffrey here already. Okay, Jeffrey, can you unmute yourself because you're muted right now. So please unmute. We can't hear you, Jeffrey. Yeah, please unmute. Maybe Professor John, you may help me. Yes.
Yeah, he is.
Yeah.
Can you hear me now?
Hi, Jeffrey. Yes. We can hear you loud and
hello.
Right now.
Good evening, everybody. Yeah, I'm only most senior in age, not in other ranking. Nice to hear so many young presenters. What they speak about seems to be in the latest trend in orthodontics. I must admit I'm outdated, but what you're talking about, the functional appliances, I have learned of it a long time ago. And the only slack we're using this is you need the cooperation of the patient who's willing to wear them. And in this line, I feel you have a better chance because the compliance of wearing it may appear to be easier for the patients. Am I right in saying so?
Yes, you certainly is right.
Yeah. So better not let me impart the outdated knowledge from me. My knowledge is outdated. So nice to see you and nice to know so many have attended this lecture. Thank you.
Right. Thank you so much, Jeffrey. Yeah, for your kind words. It's such an honor to hear from you, and it's so nice to have you here. You still look very young. All right, and you are really a role model for many of us. All right.
Thank you.
Yeah. So yeah. So allow me to ask two more questions, Professor Jean, before I hand over to my co-chairman, Professor John. Okay. So the third questions is that right. The American Dental Association of Orthodontics actually recommend that the first age for orthodontic treatment, or at least the assessment, should be at the age 6. All right, and then that is a pre-adolescent, and then age 12 during the pubertal growth spurt will be the adolescent, and then age 18 will be the adult phase. So in your opinion, Professor Jean, is that right? What age should we start an early treatment of class 2? And would it make a difference if you start at 6 compared to if you were to start at 12, or compared to if you were to start at 18? Okay, Professor, can you please enlighten us on this? Thank you.
Yes. Yes, this about the early treatment. Yes, different lecture gave us different answers. So maybe according to my experience, answer your question. Yeah. We should start the treatment before 8 years old in class 2 cases. The cases are in the CVS2, CS3 period. They have a great potential of the mandibular growth. We can get both dental and skeletal changes, and the condyle can have a great growth and development. If they can have rotation, regional treatment at the early time, they can get the coordinate profile. The difficulty of next stage will be easy. If we start treatment at an early time, we can we can forward mandible and get the ideal occlusion and the profile. If it's in mixed dentation or early permanent dentation, like 8 to 10 years old, we can choose some functional appliance to promote mandibular growth. If it's 12 years old, we should distinguish its CVM. If there are some potential of growth, we also use some functional appliance to correct retroganism, such as activator or Franco 2, maybe Invisalign first. Yes. If there are some potential of growth, but there are little potential of growth. Maybe we use orthodontics treatment to retract the upper incisor. Maybe extracted some teeth, and rotate the mandible. Yeah, counter clockwise rotation. Yeah, it helps the profile improvement. Yeah. Maybe if it's adult patients with severe skeletal mandibular, such maybe 18 years old, yeah, you may make also genetic treatment, including DO and also genetic combined treatment to correct the abnormal occlusion and profile. Yeah, so it's surgery. Yeah, in our country, it's popular to correct the skeletal malocclusion, use surgery. Yeah.
Thank you. Okay, so now I'd like to ask my co-chairman, Professor John Ling. Okay, Professor John Ling, you may carry on to ask some question and take over to chair this session now. Okay, thank you.
Thank you, Professor Jean, for a very interesting lecture. I would like to have a couple of questions. Number one is we do realize sometimes children do have temporomandibular joint disease, such as idiopathic condylar resorption, is one. And the other one is asymmetrical face, such as hemifacial microsomia. So in this instance, if they have a diseased joint, would you consider treating them with functional appliance? You wait until they are fully grown to consider other means of treatments, such as surgery.
Oh, thank you. Thank you, Johnny. Question is about condylar resorption. I think it's very difficult for orthodontists to correct it. Yes, you know, I found some children, yes, had the condylar resorption. It's not clear reasons, yes. So maybe I can use some functional appliance like occlusal plate, and maybe just try. Yes, maybe it's good, maybe it's bad, maybe it's the same. Yeah. So I'm not make sure about it. Yes. It's difficult, I think. Yeah. But for orthodontists, you must pay attention to that patients. Yes. it's a trap, I think, a big trap.
Now, the second question, is there any contraindication use functional appliance, such as if they have a long face syndrome or a high angle, if you consider the use of functional appliance, high angle case?
Yes, it's a high angle cases. I think maybe it's very difficult. Class 3, skeletal class 3 is with long face with high angle. It's very difficult. You can't evaluate their growth and development. Yes, so for some long face and with high angle, maybe we wait for 18 years old to surgery about it. Yes, I think most patients maybe need a surgery. Yeah, so we just wait to growth. Yeah, sorry. Yeah.
Now,
in my opinion, yes, just. But I want to know how to treat it for you, for Johnny. Yeah.
well, I will wait to the high angle. Probably do probably extraction or use tests or anything like that.
Yeah.
Personally, I would wait if they have a high angle, because you can make them worse if you do the function.
Yeah. Yeah.
Do you notice any difference between the genders? That means the girls work better than boys for functional appliances. Do you notice any difference? Because in the UK, there was a study there is a difference that the girls are treated better with the function than the boys. You notice that in your center, your university? Or because they are more compliant, that means they listen to the doctors and they wear it. How often do they not wear the functional appliance in the institution?
Maybe
10-20%?
5%, yes, according to the different age. Yeah. Different growth. Yeah. CS, yeah. You know, my study, my research is about the class 1, class 2 patient growth and development, including mandible, maxilla, yes, and some length, head, rotation, yeah.
How many actually, when you use your functional appliance, did not go through the whole treatments? That means they give up in the middle.
In my clinic?
Yes.
Yeah.
Probably very good.
Yes, I think it's very useful for correct mandibular retrognathia. Yeah. So I use it, but you know, we need patients' cooperation. Yes, it's difficult. If the patient wear the functional appliance according to my idea, its result is very well. Yeah, for in my clinic. Yeah, but
how do you make them wear? You are supposed to ask them to wear it full time, or like an activator. You, of course, we ask them to wear full time. But how do you double check they are actually wearing it full time, or they just wear it when they see their mother and then they put it in the mouth?
I can't control my patients.
When they go to school, they probably remove it.
Where this functional appliance. Yeah.
Yeah. So if you, Do you use herbs in your clinics?
So pardon?
Because in Hong Kong, we do use a lot of herbs when Professor Hay was here. The herbs
Pardon?
of plants.
Functional plants.
I mean, they're herbs. Herbs.
Herbs, yeah.
Yeah.
Herbs. I use I had used the herbs just one just 2 cases. Yes, it's very well, but it's very complex to how to say. Usually I use the forces. Yes, yeah, forces. It's very for me maybe it's very simple to made it to wear. Yes. So and it's very useful. I think it's very good. But you know, when you use the forces plants, you must grasp some ideas, some principle. Yes, how to use it. You need in the upper arch TPA. Yes, to control the vertical of molar.
Excuse me, Professor John and Professor Jean. I have a question from Indonesia from Dr. Andrew Lauren. He's asking that regarding the TMD patient, all right, what we should consider if we want to use fixed appliance to correct the class 2 malocclusion, the post-TMD treatment patient. All right, that means people with temporomandibular disease patient. All right, do you see it as a contraindication to do the fixed appliance treatment or the functional appliance treatment? So Andrew, I hope I asked the correct questions for you. Yeah, Professor Jean, did you catch my question? My question is that patient will have a joint problem. All right. Yeah. So is there a problem for them to use the fixed appliance treatment or functional appliance treatment with the temporomandibular joint?
You mean forces?
Yeah. Any one of them. Forces is one.
Anyone?
Yeah. Fixed appliance. Forces also. Yeah.
Yes. For fixed appliance, how to say?
You can explain in Mandarin, and Dr. Hao and I will translate.
Yes. Okay. Yeah.
It's okay.
Maybe I'll help you out here.
Yeah. Okay.
If a patient comes to us already have the joint pain of disease of the joint, is it advisable we would recommend orthodontic treatment to treat the malocclusion and hopefully the joint disease will improve? Or we should not do the orthodontic treatment if there is pre-existing problem relating to the TMJ. That means should we treat it if patient have a problem already, existing problem, or treat it, the disease already treated, and then when we do the treatment, make the patient bad again. So would you, do you have TMJ patients, TMD patients go into your clinic and asking for treatment?
Yes, in my clinic, there maybe sometimes there are patient with TMD. For me, yes, I think TMD is very complicated. Yes, and its etiology is not clear. So just use some idea for the TMD. I think maybe orthodontics can't correct the TMD. Maybe improves some yeah, but I think I can't
Yeah, maybe
we
Professor
can't cure the
maybe Professor Jean allowed me to share my personal experience. All right, and also for Andrew Lauren. All right, maybe I would like to also take this junction just to share some of my personal opinion on TMD. All right, actually, in my view, is that first of all we have to establish what is the causes, or we call it the etiology of
yeah.
the TMD. So if it's due to occlusion, for example, a deep overbite is one of the contributing factor. Okay, and the other one is a premature contact with displacement of the jaw. Either is a forward or sideward displacement that also can cause a TMD problem. And the third type is actually what we call a canting of the occlusal plane. That means one side is lower, the other side is higher. Let's say the left is lower, right is higher. That will cause the TMJ. One side is lower, which is actually in what we call a stretch, and the other one is higher, which is compression. So you have a compression and the tension, or we call it a stress and strain relationship. All these things is a predisposition of a TMD. Okay, so these are all due to the occlusion. But however, there are some sort of TMD problem. It can be due to a condyle damage, that's a structural damage, or it can be due to a bone disease, a degenerative disease. All right, so that will be something is more like a connective tissue problem, or a structural problem, or anatomical problem. Okay, these are considered some of the things that maybe not able to help so much in terms of orthodontic correction. However, if you can establish a malocclusion origin as your etiological factor, then you will find that orthodontic treatment, whether is it fixed appliance treatment, functional appliance treatment, or Invisalign, they are all aiming towards the correction of these contributing factors, then they are definitely beneficial to relieve the pressure on the TMJ. So in my practice, I treated a lot of TMD problem. Then what we normally do is that we would take various X-rays. From a two-dimensional X-ray, we take OPG as well as PA scout, capnometric, as well as the CBCT of the joint. Then if it's then we usually would treat them, and the least we can do is to relieve the signs and symptoms, and then usually patient has gone into remission automatically. All right, so that's actually my 2 cents of the opinion in that. So hope my good friend Professor Jean, you don't mind. There's also associated question from our Vietnam region, Professor Huang Chun Hong. Okay, Professor Huang is actually from the Ho Chi Minh University in Saigon. Okay, he also asked about TMD problem. What Professor Huang said is that, have you found any side effects to TMJ when the child grows up until now? Meaning that if you had treated a child with a functional appliance to correct the class 2, after the treatment, do they have side effects from the TMJ? Yeah, So
Yeah.
first of all, I just share my personal experience. I find that if you have corrected it and you do not leave all the contributing factors like we mentioned about premature contact, displacement, deep overbite, and deep overjack, okay, usually the answer is no. All right. But if you still leave some of the problems uncorrected, it might predispose to that. But I'm gonna ask the wisdom of my good friends. Okay, Professor G, maybe you can comment on this thing. So, okay, yeah. So, Professor Jin, do you have anything to add on to what I just mentioned just now?
Yeah, I
Mhm.
agree. Yes, I think it's very difficult to answer. Yeah.
Yes,
Yeah.
it's not an easy question indeed. Okay. So, John Ling, if you have, do you have anything to add on? I think the time is about 11 o'clock. I think we should call it a day. All
Yeah.
right. So we should wrap it up right now. And you have last few words to say before we pass on to our education chairman, Professor Mat Ibrahim, and then we wrap up tonight's session. I'd like to thank everyone here. Many of you are orthodontists, and then many of you are postgraduate orthodontic student from the Hong Kong U, as well as from many countries. Also the diploma in orthodontic students. All right, so many of you who stayed up and have intense interest in orthodontics. So I hope this session has been beneficial to all of you. Okay, there'll be many more orthodontic sessions from now until August. All right, this is our team here for these 2-3 months will be all in orthodontics. And then we hope you can continue to log in to join us. We'll be happy to share knowledge with you. Okay, Professor John Ling, over to you. All right.
Well, on behalf of Section 15, I thank you again, Mr. Jin, for your time and effort. And we learned a lot from you today. Back to our chairman, Dato Professor Mohammed Ibrahim.
Yeah, it's an old friend. I'm honored to be talk about some approaches, some how to say hot point of orthodontics. Yeah, it's very well. Yeah, I like it. Yeah, I have to.
Also the diploma in orthodontic students. All right, so many of you who stayed up and have intense interest in orthodontics. So I hope this session has been beneficial to all of you. Okay, there'll be many more orthodontic sessions from now until August. All right, this is our team here for these 2-3 months will be all in orthodontics. And then we hope you can continue to log in to join us. We'll be happy to share knowledge with you. Okay, Professor John Ling, over to you. All right.
Well, on behalf of Section 15, I thank you again, Mr. Jin, for your time and effort. And we learned a lot from you today. Back to our chairman.
Somehow I cannot speak.
Dato Professor Mohammed Ibrahim.
Can you close up because I cannot talk. I'm muted. I don't know, somebody muted.
Yeah,
but I show the slide for the 28.
To be
Very sure. I can't speak. Something wrong with my.
Some approaches,
Professor Ibrahim, we can hear your voice.
Okay, Professor Ibrahim had just called me to apologize that he's unable to unmute himself. All right, so he has requested me to assist him to do the closing. All right, so our next speaker, all right, it is actually Professor Liu Yi from Beijing University. He's a professor in orthodontics. He's also the FDI International Liaison Officer for representing China in the World Dental Federation, and he speaks perfect English. And then he's also the International Relationship Chairman of the Chinese Stomatological Association, also CSA. So Professor Liu Yi would like to share with us on the 28th of July, which is 2 weeks from now, about the principle of early orthodontic management. So as we notice that when we begin the orthodontic, the age is getting earlier and earlier. We used to start in teenager, then after that we went to adulthood, and now we go earlier back to teen. In fact, we go into pre-adolescent, which is about 6 years old, we begin to start. So, and tonight our Professor Jean's topic also on early treatment, and now Professor Liu also wanted to share. So now we want to hear another versions of early orthodontic treatment. This time will be from Beijing. And then thank you, Professor Jean, sharing experience from Xi'an. All right, now we want to hear from Beijing the next time. So we welcome every one of you to log in again to listen to Professor Liu. All right, and then as for now, I want to thank every one of you who has attended it and who have persevered until 11 o'clock. All right, so thank you very much again indeed for everyone. Bye for now. Thank you very much. Okay, cheers. Thank you, Professor Jean. Thanks, 周玲，谢谢你。